Good afternoon, everybody. Thank you so much for joining us again in this community chat. My name is Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. This month is Colorectal Awareness Month or Colorectal Prevention Month. So today we're going to be talking about colorectal cancer. And for that, we have Dr. Tater here. He's almost famous for us because, you know, he's been here every year helping us with this chat, and we're very happy to have him. And I'm gonna first start by asking you to introduce yourself, Dr. Tater. Maybe you wanna tell us about your practice, what you do, what you got into, how you got into this.
Okay, so I am basically I've been here in Rockland County for about, I don't know, about 17 or 18 years now. I'm with two other people in the county. I'm with Dr. William Silver and Dr. Svetlana Kornfeld. We have an office in West Nyack, and we go to both the Montefiore Nyack here and also to Good Samaritan Hospital. Obviously, as a board certified gastroenterologist, colon cancer screening is, you know, probably one of the main things that we provide in our practice, along with other things, everything from liver disease to pancreas issues to reflux to diarrhea, constipation, that kind of stuff. But in any case, in terms of colon cancer screening, obviously it's March, and so it's Colon Cancer Awareness Month. There are a number of things to know about colon cancer, and so I think I'll kick it off with that, if that's okay.
Go ahead.
The reason that colon cancer is talked about so much and that it has such prominence in, you know, thought when it comes to, you know, preventive care is that it's unfortunately common. Okay, it is actually the second leading cause of cancer death in the United States after lung cancer. There's over 150,000 people a year diagnosed with colon cancer here in the United States. And there's about 50,000 deaths a year from colon cancer in the United States. So 50,000 people a year die from this in our country, okay? And that's every year. If you look at it maybe a different way, maybe looking at it from your perspective, you have a 6% lifetime risk of getting colon cancer statistically. And that's if you're an average individual. If you have a family history, it may be double that, okay? Now, 6%, all right, maybe that doesn't seem like a lot. Obviously, it also means you have a 94% chance of not getting colon cancer, which sounds a lot better, right? But on the other hand, if you were to go walk around the Palisades Mall, for instance, right here in Rockland, you're probably going to see 100 people over the course of just a few minutes. And then to think, wait a minute, 6 out of 100 people get colon cancer. That's 6 out of those 100 people that you just saw during their lifetime. So it is out there. And the fortunate thing is that it, for the most part, can be preventable. So just like people get mammograms, prostate exams, whatever, cervical exams, getting a colonoscopy is a preventive screening measure, and it does undoubtedly save many lives. Okay. Now, when it comes to screening, the purpose of doing the colonoscopy is to look for little polyps in the colon, which many of you are aware of what polyps are. They are abnormal growths in the wall of the colon. They can look like little balls in the wall of the colon. And when we do the colonoscopy for screening purposes, if we find a colon polyp, we can remove them right there and then during the procedure, and thus prevent getting colon cancer down the line. Now, these polyps are slow growing, okay? They may take 5, 10, 15, maybe even 20 years to get larger and transform into cancer, but undoubtedly over a long period of time, they most likely will, okay? Not all polyps are precancerous. Some are hyperplastic, they're called, which have no cancer potential, but most of them are precancerous, and there are several different types of precancerous polyps. But the main idea is that they do represent a low-level mutation in the cells in the lining of the colon where they do not detach and slough off like normal cells do as they wear out, and they become adherent there. And then maybe with a second mutation at some point, then that's when they transform into cancer. So there is a nice window of opportunity to go in there and remove them. Now, interestingly enough, for a person at age 50, which is what we used to use as the guideline for starting colonoscopies. It's now actually been changed down to 45 in the last 6 months or so. It's been changed down to 45 now. But the statistics show that for an average individual who's 50 years old coming in for the first colonoscopy, we find a polyp in 1 out of every 4 people. So you have a 25% chance of having a small polyp in there when you come for your initial colonoscopy. That's been shown in the literature.
At age 45.
Well, that's data based on 50, but 45, I'm sure you're going to be picking up a lot of polyps as well. Okay, maybe they're even a little smaller at that point. Okay, but basically the thing to remember is 1 out of 4 people that are getting a screening colonoscopy, we find a polyp in. Okay, so 25% chance. All right.
And how fast do these polyps grow, Dr. Tater?
Well, every individual is going to be different, and every polyp is going to be different. So it's hard to say an exact time period, but as I mentioned before, is probably on the course of, if there's a 3 millimeter polyp in there, I'd say probably it's going to become cancer in about 10 years, maybe 10 to 15 years. But there are cases where people have polyps that spring up and they grow much quicker. It is not unheard of to have a patient who even gets a colonoscopy and 6-7 years later, now they have cancer, and there was definitely nothing seen on colonoscopy. Now, you have to also remember that a screening colonoscopy is not perfect for finding a polyp. They have done studies where they had somebody get a colonoscopy, but they didn't remove the polyps, and then had another person do another colonoscopy a week later, and to compare, how many polyps were found, to see what the find rate is, the encounter rate is for polyps. And it's not 100%. Okay, it's possible that maybe 2 or 3 or 4% of polyps that are there don't get seen for whatever reason. Maybe the prep's not perfect. There's a little bit of spooge in there, whatever you want to call it. Maybe it's hidden behind a fold. So when you do a colonoscopy, there's probably a 97% chance that you're going to find a polyp if it's there, but there's still 3% of those that are in there that get missed. The thinking is that the next time you go around to get a colonoscopy, you're going to find it at that point.
And how often do you need to have a colonoscopy?
Well, all right. So we were telling everyone to do it every 5 years in the past. However, the Center for Medicare and the guidelines switched that over, and they want it actually every 10 years now. That's if we don't find anything. They want it every 10 years. Now, personally, I think that may be a little too long, in my opinion, but I'm not the one that made the guideline. Okay. So my own opinion is after 7 or 8 years, the protective effect starts to drop off fairly steeply. But I think they made it to every 10 years because people tend to remember that better. Okay, I had a colonoscopy in 2022. That means now I'm due in 2032, because they didn't find anything. So I think that was part of their thinking in that. I don't know, to be honest, what the statistics were that led them to that. But my own opinion is 10 years is probably okay. It's appropriate, but it does make me a little nervous that last year or two of that 10-year period personally. Okay.
Now, you said that's if they don't find anything in that colonoscopy. So what if they found a polyp?
Well, right now the guidelines are if we find 1 or 2 small polyps, you can return in 5 years. And if we find 3 or more polyps, you return in 3 years. And if you find a very large polyp that's bigger than 1 centimeter or 1.5 centimeters, it's reasonable to return in a year, just to look at the site and make sure there's no residual tissue when you removed it. The other thing to be aware of is that if you have a family history, you may, even if you didn't find a polyp, you may need to come at a more frequent interval as well. And the guidelines for that are a little confusing, but basically they're as follows, if you'd like to know. So if you have a first-degree relative, like a brother, sister, or parent, or an offspring that had colon cancer, the recommendation is to start screening 10 years before that family member had colon cancer, or at age 40. That's what the guidelines are. So if your father, for instance, had colon cancer at age 45, then you would start at age 35, 10 years before. Okay. If your father had colon cancer at age 75, then you'd start at age 40. Okay. And if you have the first degree relative, then the next thing you look at is how old they were when they had colon cancer. If you go by the guidelines say that for people under age 60, if the family member was under age 60, then you should do a colonoscopy every 5 years. If they were elderly, even if it was your father that had colon cancer, but they were 75 or 80 when they had colon cancer, you can still do it every 10 years according to the guidelines. But again, these are guidelines. I think a lot of practicing gastroenterologists and physicians are still recommending that people come every 5 years. But I can only tell you what the guidelines say. So they use the age 60 as a cutoff to how frequently you come. If you were under 60, the risk is higher. If the family member was over age 60, the risk is lower.
Now, does it mean that when they find polyps that you're going to have cancer if you don't take care of yourself, or not necessarily?
Well, no, we remove the polyps. We take them out right there and then. So that prevents the cancer from occurring. It doesn't necessarily prevent new polyps from popping up later, but that's a slow process, as you know. So there's plenty of a nice window of opportunity to go back in and look. But when we do the colonoscopy, we either put a little snare, like a little lasso around the polyp and sort of decapitate it, as it were, with electricity to remove it, or we grab it with some little pinchers and we pull it up and then burn it off with electricity. So we destroy the tissue around it. Occasionally, if they're really, really small, we can just pluck it off without having to use electricity. So we obliterate and remove these polyps when we see them. So you shouldn't be getting cancer from them.
Okay. Now, we're getting already questions. Some of these questions that I'm asking you are already from our participants. So one of them is there an age at which the risks of colonoscopy outweigh the benefits?
Yes, there is. And if you look at the guidelines again, they say that certainly after age 80, we probably shouldn't be doing colonoscopies on everyone for just screening purposes. I mean, if somebody's anemic or they're having rectal bleeding, then that's another story and they're over age 80. But if we're just doing it purely for screening, usually we use 80 as the cutoff. However, the guidelines also say that 75 is appropriate as the termination time if the patient's not well. I mean, if you have lung disease, kidney disease, heart disease, then we may stop doing the screening earlier, like at age 75. So I would say between 75 and 80 should be your last colonoscopy, depending on your health.
Mm-hmm. And DR just wrote a comment here. She's saying, to add to what Dr. Tater said, I had my first colonoscopy at age 50 because a good friend died of colon cancer at age 52. I had 2 polyps, they were removed, and I was grateful I had this life-saving screening. Mm-hmm. And here is another question. Most of my patients do not like to have an invasive screening. Could you please talk about the other options of a screening and which one is the most effective?
Certainly. Okay. So the one of the methods that's getting a lot of press is Cologuard, which you've probably seen commercials for. But you have to realize the limitations of that test, okay? Cologuard is a test that comes back. It's a stool sample that gets sent in. It costs like $700 or $800. It can come back positive if either A, you have blood in the stool, like microscopic amounts of blood in the stool, and that can occur from anything. That can occur from blood from your stomach if you have gastritis, or maybe acid reflux causing ulcers in your esophagus can bleed a little bit, and that can trigger that test to be positive, okay? Not only that, but you can do a $5 stool for guaiac or a $10 FIT test, which is a fecal immunohistochemical test for blood in the stool, which costs, as I said, $10, not $700. And if that comes back positive, there's no real need to do a Cologuard test, okay, for $700. So the other thing that the test checks for is certain types of DNA in the stool. And that obviously a $5 guaiac test is not testing for that, or a FIT test does not test for that. But the company doesn't differentiate in the results, whether the results came back positive because of blood in the stool or because of positive DNA. And the company is doing that on purpose because they are basically, they don't want you to know that you're, why the test came back positive. Maybe that's because the practitioners might get wise to what's going on with this test. So, so one thing I always recommend if somebody's doing a Cologuard test is why don't you just do a $5 stool for blood first? Because if that comes back positive, there's no need to go through the Cologuard test, okay? Now, in terms of the efficacy of Cologuard, it turns out that it's really a test for detecting cancer that's already there. It's not necessarily a test for preventing cancer so efficiently, because the test is only effective, mostly effective, I should say, for finding lesions that are bigger than 2 centimeters, which is maybe about this big, okay? So that means you have to have a really large polyp in there in order for it to be definitively positive, the test. If the polyp is between 1 centimeter and 2 centimeters in size, then the test is about 40% accurate, okay? Whereas if the polyp is greater than 2 centimeters, it's like 93 or 94% accurate. But for smaller polyps that are not cancer yet, that are precancerous, that might not be cancer for another year or 2 or 3 or 4 years, the test is not so accurate, okay? As I said, 40% accurate for finding a polyp between 1 and 2 centimeters. And for a polyp 1 centimeter and below, the test is only 20% accurate, okay? So the test it's certainly better than nothing. If you don't want to get a colonoscopy, no problem, but it may not pick up small polyps that are precancerous years before they become cancer. They're only going to be accurate at finding larger lesions. They may still be a big polyp that has not transformed into cancer yet. That's quite possible, but you just have to realize that that's the limitation of the test. Okay, and that's not just my word. This is the New England Journal article from about 7 or 8 years ago on it. These are the statistics that were reported. Okay, so it's a great test for finding a big, huge polyp or a cancer that's already there. It may not be a good test for finding a small polyp years and years and years before it becomes cancer. The other issue is that they want you to do it every 3 years, and that's the reason why, because it doesn't pick up the small ones, so it doesn't give you a nice 10 years of protection like a colonoscopy does. So they want you to repeat it every 3 years. And the other thing is that it's not warranted or approved for people who are seeing blood in the stool or who have a high risk of colon cancer, such as a family history. So technically you're not supposed to use that test if you have any kind of symptoms, alarm symptoms, or a family history where you're higher risk. So those are some of the limitations. Now, that being said, listen, I mean, if people are completely averse to getting a colonoscopy, absolutely, it is a better option than not doing anything. No question about it. But it is not considered first line screening. It's considered second line screening for those people who just don't want to do a colonoscopy. That's kind of the bottom line on it. Okay. And well, trust me, there are plenty of people they don't want to go through an invasive procedure. I understand that.
So it sounds to me like Cologuard, colonoscopy is definitely preventative, while Cologuard, you already must have had something going on.
Well, I mean, look, I do get people with positive Cologuard tests coming into the office, and then of course, obviously it gets a little concerning if we do a colonoscopy, and I always do an EGD on them as well to look for bleeding in the stomach. But if you do both of those and you don't find anything, then you're like thinking, oh, wow, why was the test positive? Did I miss something? But as I said, it's definitely, it's not the gold standard. Let's put it that way. It's not the gold standard, but if people do not want to get a colonoscopy, or maybe they can't get it because it's too risky, or maybe there's people from group homes who can't take the prep. It's certainly a reasonable option in those cases. Or if you're just totally averse to doing a colonoscopy, it's not like you're on the fence and you're just like, I'm not doing it, then it would be warranted to do. Now, if it does come back positive, then at that point, then it does warrant that you get a colonoscopy and probably an endoscopy as well. So be prepared. If it does come back positive, then you really have to get something done.
So Dr. Taylor, you just mentioned that colonoscopies have some risks. So what will be the benefits and what will be the risks?
Okay, well, definitely. I mean, look, it is an invasive procedure. You get sedation All right, so, obviously you have to make sure that you're breathing fine and everything like that. Now, fortunately, we never had any major issue in our office in the 17 or 18 years that I've been there, but it is always a possibility, especially if somebody's very large, has bad sleep apnea, lung disease, or something like that, chronic smoker, these are risk factors with the anesthesia. Okay, so that's one thing you have to be aware of. You can technically get a colonoscopy without any anesthesia. It's done in many countries actually, but I would say half the time somebody gets a colonoscopy with no anesthesia, they're totally fine and they're sitting there just watching and whatever. And half the time they really wish they had the anesthesia because they're going and it's not pleasant. Okay, so I can't predict that. But I have had a number of patients at times that said, I don't want any anesthesia, and they did just fine. But on the other hand, as I said, lots of times people are blessed the anesthesia afterwards and say, oh my God, thank you, thank you. So anesthesia is one issue. When you find and remove a polyp, there's always a small chance that you could cause some bleeding from the site. Maybe the bleeding even occurs a week or two later, okay? Because you can form a little scab, like if you got a cut on your hand, and if that scab falls off a week or 10 days later, it could start to ooze blood. And unfortunately, with your hand, you can just put some pressure on it or a Band-Aid on it, but internally in the colon, you can't reach it and put any kind of pressure on it. Just like that, you can't do that. So there is a risk of having some bleeding afterwards, but mostly these are people with blood thinners. If people are on Plavix or Xarelto, and they go back on their blood thinner a few days after the procedure, and all of a sudden now they start bleeding from the site. And it does happen. I mean, I'd say it happens maybe once a year to a patient of mine. And I have had to go back in and repeat the colonoscopy and put a little metal clip on the spot to pinch it shut so it stops bleeding. I have had to do that in the past. Those clips fall off after a few weeks. So that is a risk of the procedure, but it's a minimal, small risk. And then it is possible that you could tear the lining of the colon, a perforation with the colonoscopy. That can happen even if you did everything the right way with the procedure. The risk of that is 1 in thousands and thousands and thousands of times the procedure is done. I think it's somewhere around 1 in 4,000 colonoscopies or so. But that can happen, in which case, if you identified a perforation right at the time of the procedure, you'd have to send the patient to the emergency room to have a surgeon go in and sew shut the tear right away. I have been practicing, as I said, for like 17 years here or whatever. I've probably done maybe close to 20,000 colonoscopies. I have had it happen twice in my career. Both times the patient did just fine. If you look at it statistically, that's maybe 1 in 8,000 or 9,000 colonoscopies. So I guess my statistics are better than the general statistics that are out there. It's not 1 in 4,000, it's 1 in 8,000 or 9,000. So I guess that's a good thing. But any GI doctor, it's going to happen to once in a while. It's going to any GI doctor, it's probably happened to it at least once or twice in their career. And both times that happened, it wasn't anything unusual going on. It wasn't a difficult colon or anything. It's just whatever the case is, the person was, maybe they were very thin. They don't have a very, elastic tissue in the colon or whatever. And it just wasn't able to withstand the pressure of the scope going through. So, but that is a risk of the procedure, but it is minimal. I mean, your risk of getting colon cancer is much higher than the risk of having a perforation or a complication from the procedure. And the way that I often tell patients is, look, you could walk across the street and get hit by a car. Okay, that doesn't prevent you from walking across the street, but it is a risk of doing it. So the same thing with a colonoscopy. There's a risk of having those things happen, but it shouldn't necessarily prevent you from doing it just because the benefits outweigh the risks. Are there other risks? I suppose, you could irritate the spleen with the scope or something like that, but those are very, very, very rare. Okay, any other questions?
So you mentioned that bleeding. Is that a bleeding that is extremely concerning, like you're going to have to go to the emergency room because you get so scared, or it's just like a little tint, or you know what I mean?
No, I mean, look, if somebody has a minimal amount of bleeding that from where you took out a polyp, we'd probably just wash them. I mean, if it was just a little scant amount of blood in the stool, it would probably just stop on its own. And plus, you know, I mean, it could be from hemorrhoids or anything else too. But, you know, it doesn't happen too often.
Now, let's talk about symptoms a little bit, because we got a question here from JS. Does mucus in your stool indicate a problem?
No, it's normal to have mucus. Your cells in the colon secrete mucus to keep it lubricated, to protect the lining of the colon from invasive bacteria and viruses and other objects. So mucus is a protective thing that's secreted in the stomach and in the intestinal tract. So if you're seeing mucus, it's not necessarily anything abnormal.
So what are some of the symptoms that we should be watching for if we are scared that we're going to get colon cancer?
Well, I mean, the main one would be blood in the stool. If you're seeing, you know, rectal bleeding, and especially not just like a little bit on the toilet paper when you wipe your hemorrhoids, but I mean, mixed in with the stool would be very concerning. I mean, even if you see a little bit of stool blood on, like when you're wiping, you should still see a doctor about it. But the most concerning would be blood mixed in with the stool, clots, repeated bleeding over a period of time, not just one isolated episode, you know, weight loss, abdominal pain, maybe a change in bowel habits where all of a sudden now you're not able to evacuate very well and you don't know if there's a blockage down at the bottom. But a lot of times, you know, colon cancer is not easy to detect until it's metastatic and an advanced stage. You know, the colon cancer tends to metastasize first to the liver, and that's because the blood supply from the gut travels to the liver where things get detoxified and processed. So that tends to be the first place where lesions would be seen. You know, it depends where the colon cancer is. If it's down by the rectum, it's going to be probably easier to detect. If it's in the very up high in the cecum, it may get very large before you run into an issue. Also anemia, if people are anemic with low iron levels, that could be an indication of colon polyps or colon cancer. So anybody who's anemic, you know, that has to be a concern going through the mind of the physician that's evaluating that.
Are there any, artists asking, are there any specific dietary recommendations to help decrease the risk?
Well, it turns out that mostly the risk is genetic. I'm sure that diet does play a role, but it's only a minimal role. So it becomes difficult to tell people to change their whole lifestyle in the thought that they're going to prevent colon cancer, because you could be a marathon runner who's a vegan and still get colon cancer, and it wasn't because you were, you know, it wasn't that your diet prevented it. Okay, so you have to keep that in mind. I would probably say 90 to 95% of this is just genetic, but there is a component that is associated with lifestyle, and obviously smoking will increase your risk. Alcoholism will increase your risk. Eating a lot of charred meats will increase your risk. And high-fat diet will increase your risk. High-fiber diet tends to slough off the cells on the outside of the colon with more ease, because the fiber, as it passes through with the bowel movements, can sort of scrape off the dead cells there. So that would high-fiber diet would decrease the risk. And studies have shown that taking aspirin can decrease the risk of colon cancer, but only in patients who are super duper high risk, like recurrent colon cancer or patients with polyposis syndromes. There are a lot of risks to taking aspirin, though, including kidney risks and stomach ulcer risks. I don't know that I would say that the benefit from a colon standpoint outweighs the risks that you would get from a gastric ulcer standpoint. Remember, aspirin works by decreasing mucus secretion, believe it or not, and mucus is protective to the intestinal tract, and it helps prevent stomach ulcers. So, so I would have to say there's a trade-off, you know, in terms of using aspirin to prevent colon cancer, and it's not currently recommended in average risk patients.
Is Is the colonoscopy only used for prevention, or is it used for diagnosis as well?
Well, I mean, we're talking about screening for prevention, but diagnosis is used for if you're anemic, you're trying to diagnose why you're anemic. If you have diarrhea, it may be useful for looking for things that can cause diarrhea in the, infections, or maybe even types of colitis like ulcerative colitis or microscopic colitis like lymphocytic or collagenous colitis that can cause diarrhea, Crohn's disease. There are things that colonoscopies are used for, for diagnostic purposes. But, I mean, right now we're talking about colon cancer screening, but, certainly, colonoscopy is used to diagnose, abdominal pain, diarrhea, constipation, blood in the stool, anemia, those kind of things, abnormal CAT scans, stuff like that. So you can do a diagnostic or a screening colonoscopy. I mean, it depends on what's going on with the patient.
Mm-hmm. Now, hemorrhoids and constipation are pretty common. Are they, people with hemorrhoids and constipation, are they at higher risk for colon cancer?
They're not at higher risk, but it could be that those are signs of something going on in the rectum that maybe they're not suffering from hemorrhoids. Maybe they're suffering from a tumor in there. You know what I mean? So it could be an alarm symptom if you're seeing blood in the stool or you have a sensation you cannot evacuate. That may be something that should be evaluated just to make sure that you're not assuming that they're hemorrhoids. But hemorrhoids on their own are dilated vessels that serve as a cushion to close the anal canal from the inside so you don't leak stool out. And if you're constipated, you can rough up those hemorrhoids when you have a bowel movement because the force is increased when you have hard stools coming out, and they can cause inflammation and disruption to those dilated vessels there, causing them to become inflamed and cause problems. But as I said, hemorrhoids themselves don't cause cancer, but the symptoms that you can get from hemorrhoids could mimic the symptoms that you could get from having a tumor in the rectum.
Mm-hmm. And we got another question from Mia. So most health plans cover the screening, the colonoscopy. However, if there are polyps or other complications per se, then insurance might charge for diagnosis tests.
That was changed. The US Congress changed that with the COVID-19 bill that came out like a year ago, or that was passed in like just over a year ago. So that was attached as a rider on that bill that with President Biden, where they did away with that. So you should not get charged now if we find a polyp. So it used to be when this was originally passed, and I don't know what numbskull came up with this, but it used to be that you're not charged a copay or a deductible for getting a screening colonoscopy unless we find a polyp, in which case then you're responsible for your deductible or copay. What kind of incentive is that for people to get screening if you potentially could get charged? So they did away with that. It was a bill in Congress. I was actually following it for many years, and it couldn't get through Congress. And then when they had the COVID Relief Act for like whatever trillions of dollars, they had that as a little rider. I mean, it has nothing to do with COVID, but they managed to stick that on the bill. So now, apparently now, if we find a polyp during the procedure, it still counts as a screening, and you should not be charged a deductible or copay.
Perfect.
And if an insurance is doing that, then you should approach them about that, because you should not be in the last 10 months, you should not have that happen anymore.
And Dr. Taylor, for people who don't have insurance and need this screening, how do we go about that?
Well, all right. So a couple things. First of all, we do offer, a set fee for patients in the office if they wish to get a colonoscopy for any reason, and we try to keep it rather reasonable, to help out people who are maybe underserved and not buying insurance. But there is also a county-wide program where patients can get a stool for occult blood. And if it's positive for occult blood, then they can get a colonoscopy for free through the county. Rockland County. I don't know what the number is for that. I do know that we do participate in that, and that Nyack Hospital has graciously allowed us to use their facility for the procedures for that. But I think it's only for people who have occult blood in the stool, and you have to go through the county program for that. Okay. If you just want a screening colonoscopy and you don't have blood in the stool, you're welcome to approach any of the GI practices, including our own, to discuss with them what they would charge. I don't know the exact amount, but right offhand, but it's probably in the $500 to $600 range for everything, including the biopsies and anesthesia. But you'd have to approach different people and ask them if you know, and that goes for people who are having symptoms and don't have insurance and they want a procedure done. They can always contact us and discuss with us what we charge for it. Now you have to remember there's a lot of overhead, you know, that we encounter for these. I mean, you know, the scopes are very expensive. We have to clean and process them. You know, I mean, it costs us over $150 per procedure just to process and the equipment that we use. So, you know, it's not like we're trying to be ridiculous in, you know, in the charges associated, but there's, you know, these things require a lot of overhead to run a business like that. But I won't get into that now. Okay.
Okay, but if we know somebody who doesn't have insurance and is higher risk, we can definitely refer them to you, let's say, and you connect them with that Rockland County program, or how?
No, they'd have to contact the Rockland County Department.
Directly.
Yeah, that's who runs it. I don't know where they go for checking for the blood in the stool or how it is. I do know that once, you know, for those people who are positive for blood in the stool, they are given the names of our office, for instance, and then they call us and say, oh, you know, we were referred to you by the Rockland County, and we set everything up from there.
Well, I don't have any more questions in the chat or the Q&A. So any last thoughts, Dr. Tater?
Well, the only thing is that, you know, as of this time, you know, the most recent statistics show that only 50% of people who are eligible for colon cancer screening actually get screened. So, you know, and so I think you just have to keep that in mind, that there's a large number of people out there who are not going for it. I don't know if it's in part because they just haven't thought about it, or if they've been offered it, they just don't, you know, like the idea of it. But what I can tell you is that the procedure itself is really not that bad. You know, you lay on your side, you get some medicine through the vein, you wake up 15, 20 minutes later, and you're like, that was it? It wasn't any big deal at all, okay? The hardest part really is you have to do a clean out the day before to flush out the system. You have to make sure that you read the instructions very carefully about the clean out, because if you're not clean for the procedure, we won't be able to see the polyps that are in there. But I understand that there's a hesitation, but having gotten my colonoscopy when I turned 50, I can definitely tell you from my experience, I didn't think it was a big deal at all. And you know, most of the patients that we do the procedure on afterwards, they're like, that was it. You know, they're not exactly complaining that they had to go through with it. Okay.
Yes, and you said that sometimes you can do it without sedation, so that's an advantage for some people.
I don't recommend it, but if people don't want to be sedated, then, you know, we can discuss that. I don't have an issue with that. It's, you know, look, in Japan, in other countries, I'm sure in Russia or whatever, you know,
in my country, they
probably don't use sedation in most countries. You know, we tend to be a little spoiled here, perhaps, with that. Okay.
Yes, that's right. Okay, well, thank you so much, Dr. Tater. It was today, and it's always been very educational. I really hope that a lot of us, a lot of you, family members, friends, that we tell them about colonoscopy and colon cancer prevention. We can really save lives with this. Let me just tell you that, lived out myself. So please do, you know, reach out to your doctors, reach out to Dr. Tater, reach out to the hospital, reach out to whomever it needs to be, but just save your life and save the life of others. Thank you, Dr. Tater. It's been a pleasure. I will see you soon.
Okay, very good. Thank you. And best of everything to all of you out there.
Thank you. And thank you to all of our attendees and for your questions. And I will see you next week. And next week, we're going to be talking about men's health. So it's all about men. And, you know, we're going to be talking about ED, about prostate malignancies, lots of things about men. So you don't need to be a man to participate, because I know that a lot of us are wives, are mothers, and we would like to bring this information to our families. So thank you. Have a good rest of the day and see you next week.